Good afternoon and welcome to CASLPO's COVID-19 Town Hall. Just to give you a little bit of IT advice, try and make the GoToWebinar the only site open on your computer. Even close your email. It seems to help with the bandwidth. So I am very pleased to be able to introduce Brian O'Riordan, CASLPO's registrar. Brian joins us every May for May is Speech and Hearing Month to discuss external influences on CASLPO. So I don't think any of us could have anticipated the extent of COVID-19, the pandemic, and the current external influences on the college. My name is Alex Carling. I am the Director of Professional Practice and Quality Assurance here at CASLPO. So Brian, over to you.
Thank you very much, Alex, and a big welcome to everybody. Thank you all very much for coming and spending this time with us. This is the largest attendance we have ever had at a CASLPO webinar, upwards of 1,000 people, so that's fantastic. And it is very fitting that we are hosting this webinar during Speech and Hearing Month. During this very special month, we have been recognizing the heroic efforts that all of you have been making over the last 10 weeks to fight the coronavirus and contain its spread. This year, we have dedicated Speech and Hearing Month to those who have, amongst the registrants, risked their health to help patients in need in hospitals, rehab centers, long-term care homes, and in the community, and those that have been redeployed to the front lines to fight the virus. As well, we have dedicated it to those amongst you who have put their practices on hold to protect their patients. And finally, to those who have found new ways to connect with patients through virtual care or other means during this very difficult period. We recognize that since the government proclaimed its emergency orders back in March, nothing has been quite the same. For you, for your patients, or anybody else in the wider public. It is truly an honor, I want to tell you, for us to be here today with you and to support you as services and workplaces now gradually reopen. So to begin the formal presentation, let's start with how does CASLPO get its information about COVID-19? What do we rely on to pass on to you to make sure you're getting the most accurate, credible, and best information that we can provide to you? So the first resource, of course, is the Government of Canada. The second is the Government of Ontario, and particularly the Ministries of Health and Long-Term Care, as well as the Chief Medical Officer of Ontario. And finally, Public Health Ontario. Those are the three largest sources of information for us. Just a brief word on what CASLPO's role is in the pandemic. It continues to be, of course, to regulate audiologists and speech-language pathologists in the public interest. It is to keep you updated with information from the governments and from Public Health Ontario. And how have we been doing this? I think, as many of you know, it's through our dedicated COVID-19 webpage, which we've had on our website for many weeks now. We review the information that we should be passing on to you at daily morning communications meetings, and then go ahead with either posting new information on the website or putting out a group email to you. We develop constantly communications and think about communications to send to you to keep you the best informed. We have recently developed pandemic practice advisories and FAQs. There's 10 of them now posted, and I know many of you have already accessed those. So how is this town hall going to work? First of all, many of you have sent questions in ahead of time. About 100 actually or more have come in, and many of the slides that you're going to see in the next few minutes are going to be addressing those very questions that you have sent to us. Also, you can ask additional questions during the course of the webinar by writing them into the question box on your screen. Samita Jogbekar, our audiology advisor and manager of mentorship, is here to facilitate that process. Finally, we will be sending out FAQs in the very near future for any of the unanswered questions, any of the questions that we can't get to through the slides or through the interaction with you today. Be assured, we take all of your questions seriously, and we will be answering them to the best of our abilities throughout. So, what are some of the things we're going to cover today? First of all, of course, patient care. In-person care now is allowed by the province through the amendments that they've made to what they call Directive Number 2, which came out on a Tuesday of this week. And what that directive says is something that Alex is going to go into in detail, but I think overall they're saying, of course you can now restart your care, but you are not forced to do that. You have to only restart when you have put in place the proper preparations in terms of PPEs, in terms of infection prevention and control, etc. And those are some of the things that Alex is also going to be talking about in terms of patient care, including cleaning and disinfection. We will also be talking about some regulatory topics, touching on registration, on insurance requirements, and on work refusals.
Thank you, Brian. That's excellent. So I'm going to start off with the patient care questions. And as Brian said, if you have any additional questions as we go through, please just write them in the questions box. So on March the 17th, the Government of Ontario declared an emergency. And in doing so, the legislation allowed them to develop and issue directives. Now, the directive that affected us as healthcare providers was Directive Number 2, and in effect, it stopped all in-person, non-essential healthcare. The reason this decision was taken was to help reduce the viral spread of COVID-19 and also to consolidate healthcare resources to where they were really needed. However, on May the 26th, the Chief Medical Officer of Health revoked that directive and replaced it with a new one, which provides all of us with instructions on the gradual restart of in-person non-essential services. Now, the ministry's review is that they want this to be a gradual process, a phasing in rather than an immediate start. They want to make sure that everyone has appropriate safety and infection prevention and control precautions in place before they actually initiate services once more. And the ministry go on to say that we all have to understand that this is going to be the new normal. It will not be business as usual. It will not be the types of healthcare that we provided, you know, just in February or January. It's changing. So they have highlighted some key messages in the revised Directive 2. And the first one is determine which services can still continue to be offered through virtual care. Why? To limit the number of in-person visits. This is going to be for the safety of patients, but also the safety of you, healthcare providers. Now, you'll see that I've highlighted the third point. This is the ministry are asking all of us to implement some sort of virtual or telephone system so we can consult with patients when and where possible and before they come in for appointments. We can let them know through the telephone about the requirements for masking and other infection prevention and control. And we can also do the COVID-19 screening. And they want us to source PPE, and we'll be talking about that in some depth during the town hall. So in Directive 2, they have kept the 4 principles which are to be used when deciding if you are going to have a person come into your office or clinic, or to see someone in the community, in a hospital, a children's centre, or what have you. So first of all, proportionality. That is, your decision to restart must be based on your capabilities to restart. Do you have everything in place? It might be that you might have to start quite slowly. Minimizing harm to patients. Now, what the ministry is wanting us all to do is to weigh up the benefits versus the burdens to patients of receiving in-person healthcare. So to give you an example, if there was an elderly individual who lived on their own and didn't have a car, so was traveling through public transit, if they were coming to an audiology clinic, you can really understand the burden for that particular elderly individual, and also the risk of contracting COVID-19 through public transit, for example. However, the benefit might be that this individual actually gets their hearing aid and that they are able to hear and communicate to their loved ones during this very emotional and isolating time. So whilst you're weighing up the benefits versus the burdens, also consider all available alternatives, for example, virtual care. They want the process of restarting to be fair, so we have to think of equity. And then with regard to reciprocity, they are very aware that certain patients and populations have been particularly burdened with the healthcare's limitations. So monitor these patients and make sure that if their situation changes and they become more emergent, that you do provide services. So with Directive 2, the ministry also published another document, and this is a very important document for us. COVID-19 operational requirements for health sector restart. It outlines what you need to do before you actually provide in-person services. So first of all, they want you to conduct an organizational risk assessment. Think of every aspect of your care and where you are at particular risk, what infection prevention and control measures need to be initiated. And in that process, they have something called the hierarchy of hazard controls. Now, this actually refers to all of the points below. It refers to your ability to screen patients, to have the physical capacity for the 2-meter physical distancing, that you have correct hand washing, sanitizing, etc., that you have PPE. So all of those are covered in the hierarchy of hazard control. Now you can see that I've highlighted something else, and that is signage. Now, the ministry are referring to this signage as passive screening, and they are absolutely wanting us to put up signs. Now, on these signs, are the requirements for masking or face covering and hand washing or hand sanitizing. So these signs should be just outside your door if you have a clinic. If you have a waiting room, they should be inside your waiting room, and they should also be in any office space and clinic. Also, we suggest, this is coming from CASLPO, that you have this information on your website as well to reassure the public of all the measures that you are taking to keep their health and safety your #1 priority. So, one of the questions that was sent to us regarding these decisions of do you see patients because you are allowed to now, or are you going to decide to see them virtually? So who makes that decision? Who decides what appointments are going to be in person or virtual? The answer is you do, as the audiologist, as the speech language pathologist. You are the regulated health professionals. You have the knowledge, skills, and judgment to make the determination based on patient safety, on balancing the burden versus the benefits, etc., found in the 4 principles. So it is absolutely your decision. So I am now going to stop the town hall momentarily and go to Samida and ask her if there are 1 or 2 questions about the new Directive 2.
Hi, Alex. We do have some questions coming through, none as specific to Directive 2. We do have one about consent, and I guess related to virtual care decisions. Can a supportive personnel or another scheduler in the clinic obtain the consent for the virtual care?
Okay, let me answer those 2 pretty quickly. We do have some FAQs on virtual care, so please look at those. They are in the COVID-19 section of the website. When you're getting consent for virtual care, you have to think about getting consent in 2 areas. #1, for your proposed plan of care or for the assessment. But then #2, you need to obtain consent for the actual virtual care. Okay, so you need to explain it to them in terms that everyone will understand. So can someone else obtain consent on your behalf? The answer is yes, but with a proviso. It is your responsibility to ensure that that individual getting consent has the competencies and the knowledge to do this. So you are still responsible for that consent process. So make sure also that that person is documenting consent and is covering all aspects of the consent, the risks, the benefits, etc. Okay, so thank you, Samida. So this is very timely because our next section is virtual care, and these are the questions that you submitted to us. So are assessments valid if conducted virtually? And how would swallow assessments work virtually? So the college does not require you to carry out standardized assessments. It never has done. It relies on you as the self-regulated professional to determine the best assessment protocol for the patient, bearing in mind the patient's circumstances and your circumstances. Now, having said that, I am aware that some of the publishers of tests are looking to produce versions for virtual care. So go on and have a look. Always be aware, though, of adhering to tests copyright laws. Now, the associations have been incredibly busy working on supporting you, the audiologists and speech language pathologists. And they have, all three of the associations have produced webinars on virtual care for audiologists, for speech language pathologists, working with children and working with adults. So go on to the association's websites and have a look at their webinars. Also, funnily enough, I mean, out of this challenge comes some exciting new research, because there is now research on virtual care in different areas of practice for the two professions. And Speech Language and Audiology Canada, SAC, has actually produced for everyone to access dysphagia management via telepractice. They're highlighting some of the research as well as some webinars from other organizations on how to most effectively use telepractice or virtual care in dysphagia management. So, other virtual care questions. Does it matter if the server is not based in Canada? And how do we do remote audiometry, for example, shoebox audiometry? So with regard to the server being based in Canada, it would be best if that server was based. That would be best practice without a shadow of doubt. However, we are aware, and the Information and Privacy Commission is aware of these extraordinary circumstances, and many people are using platforms that are not based in Canada. So where is the line in the sand? The line in the sand is every platform must be PHIPA compliant. And we have got an FAQ on telepractice and COVID-19 actually on our website, and it gives you information on how to find out if a platform is PHIPA compliant. With regard to doing remote hearing assessments, go back to that principle of weighing up the benefit and the burden. And if you decide that you are going to try remote hearing assessments, because that is in the patient's best interest, and you're feeling that you are sufficiently confident in the reliability of the results, go ahead, but document in the patient record why you chose this form of intervention, your rationale for remote hearing assessments. But I do also want to let you know that the college is actually currently reviewing the standards for hearing assessments, both for adults and for children, and certainly remote audiometry will be discussed. So, Samida, are there any other questions for virtual care?
Yes, we have quite a few questions coming through. Specific to virtual care, we have one. The question is, can you comment on charting and documenting your decisions about providing direct versus virtual care?
Excellent, yes. So you would use your knowledge, skill and judgment as the professional audiologist or SLP as to why your rationale for virtual versus in person. Now, you can include in that rationale that we are in a state of pandemic, and for patient safety, for your safety, and maybe you don't have the facilities to open up yet. So that could be part of your rationale as well as to why you're going to continue with virtual. So as soon as you've made your decision, often, you know, consulting with the patient as well, look at our position statement on virtual care and then document. Just document why you chose virtual care as your form of intervention, okay? So thank you, Samida. So now we're going on to infection prevention and control. And one of the questions we've had is, can COVID-19 be spread through bodily fluids, for example, found in the ear? Now, I do want to stress at this moment in time, we are not the experts at all. We rely very much on Public Health Ontario and other organisations. So we went to Public Health Ontario and they informed us that COVID-19 is spread through respiratory droplets produced when an infected person coughs, sneezes, or talks. So they did not inform us that it was spread through any bodily fluid found in the ear. Now, with regard to physical distancing, we've had questions like, you know, how do we have to stay 6 feet apart when seeing adults and children in private practice, either in somebody's home, in the office, in a rehab center, a children's center, or what have you. And then we got another question saying there's a bit of confusion out there and that they had seen something, I believe it was in one of their guides, about being between 3 to 6 feet. So we are now going to look at one of the pandemic practice advisories. So here is our website, and I am going to go into the COVID-19 page, and you will see all of the information there that Brian was talking about. We've also got another page called Providing Patient Care in a Pandemic, and I'm going to click on that. And here you will see our 10 pandemic practice advisories. So I'm going to go into the physical distancing. Here we are. And I am going to enlarge it so it's easier for you to see. So the requirement from Public Health Ontario is most definitely yes. You must stay 2 meters apart from other people in all areas of your work. So we have added here some information for you to consider on the best ways of doing this. So redesigning your physical setting, looking at your waiting room, reducing the number of chairs in your waiting room, reducing the number of people who could be conceivably waiting in your room. When you're thinking of the community, calling the family ahead of time, asking for all other family members to be in another part of the house, etc. So we've got a lot of good ideas there. And of course, use of plexiglass. If you have someone, a receptionist or someone working in the office to help you. These are all barriers that are going to be helpful. So you are, realistically speaking, going to have to get closer when you are assessing and treating your patients. So when you are closer, that is the time you really have to focus on the most appropriate PPE to protect the patient and yourself from infection. So another question we received was, I primarily worked in a hospital setting, but have a second job, and we know a lot of people do. This second job is in the community and it includes long-term care. Am I allowed to work at both places if there are no outbreaks of COVID-19 in either place? So we looked for the answer to this to Directive number 3, long-term care homes. And we're going to have to really look at the principles here. They say wherever possible, you should be limiting your work locations. You should be making every effort to limit your work locations. But that's very difficult for those of our registrants who are going into different homes, they're going into long-term care homes, and for you who are private, going into patients' homes as well. Maybe you work in a hospital, but you also have a private caseload. So the principle is limit it as much as possible. And when you are going into long-term care homes, you should only be seeing one patient per visit. So Sunita, with regard to that area, were there any questions?
Yes, Alex, there's lots of questions coming through about masks, actually, and use of masks.
We're going to be I'm going to be addressing that in PPE. So,
Okay,
was there anything else outside of masks?
Some questions on infection prevention and control in the waiting room area of the clinic, and if those precautions should be ensured in the waiting room as well as the clinical spaces.
Absolutely. So first of all, for infection prevention and control, you should have the hand sanitizers available as people come into your place. If you're working in the community, have hand sanitizer in your car. And then when people come in, another good piece of advice, which is actually in that pandemic advisory, is remove everything you possibly can from the waiting area. Remove toys, remove books, magazines, remove your educational materials, pamphlets, etc. Everything you can. Try and look at your chairs in the waiting room. See if you can get some hard plastic chairs, which are going to be easier to clean. So all of these ideas are in that pandemic practice advisory. Thank you. So here we are, personal protective equipment, a very, very hot topic. We received many questions. So a broad question would be, well, what PPE do we need in private practice? And then a little bit more specific, what is the expected policies for gloves in sessions, especially if we're doing hand washing? So I am going back to providing patient care in a pandemic, and let's have a look at the PPE pandemic advisory. So it's just coming up here on the screen, and I'm going to enlarge it again for you. So let's start off with what Public Health Ontario are telling us. I'm going to make this just one bit bigger for you. The concept is universal masking. They want you to be masked, and they are now suggesting that patients and visitors should be wearing their own masks. So you remember when I was talking about telephoning or contacting patients via virtual means in a consultation? This would be something you would absolutely do before they arrived at the clinic, to let them know that your expectation is that they will be bringing their own mask and that you indeed will be wearing a mask. Now, it might be worthwhile just getting a couple of disposable masks in case someone doesn't understand and arrives at your clinic without a mask, but it is universal masking. Now they can wear material masks that they've worn them, that they've made themselves. We've been told it should be 2 pieces of material. So with regard to gloves, what we are being told by Public Health Ontario is if you are going to be touching the patient in any way, you should be wearing gloves. So if you're going to be touching them for an assessment, for treatment, you need to be wearing gloves. So you would wash your hands, put the gloves on, the patient would leave, you would doff the gloves, and then you would wash your hands again. Remembering, I think this is a rather sad element of no more handshaking, no more gently putting a hand on someone's shoulder. With children, no more high fives. Okay, so let's do that. And another question. Now, I think this is a big concern for employers. If I supply PPE, does that make me responsible if a staff person or a patient becomes ill with COVID-19 despite our best efforts? So you must undertake efforts to comply with all of the directives and the requirements and the advice regarding PPE, active and passive screening, and of course, infection prevention and control. Should an allegation be made against you, being able to demonstrate these efforts is very important. Now, of course, you are going to be providing staff with appropriate PPE. We also suggest that you post your PPE requirements for your staff on your website or in the waiting room. And this is for two reasons. One, it is additional evidence that you followed public health's requirements and advice. But two, it does reassure patients of all the strategies and the lengths that you are going to in order to keep them safe. So, our next question. Can SLPs wear face shields so children can see the SLP's face? This, of course, would be important for many other areas of practice. Also, hearing impaired patients and clear masks, where can we get them? Where can they be sourced? So let us go back to our document, and I am going to scroll down here because we've got a lot of new information to share with you. So, first of all, we have heard, and I would like to thank OSLA for letting us know, that Health Canada Medical Directives Directorate has just authorized a brand of clear masks for importation and sale and use, of course, in Canada. Now, the Government of Canada also released a document of COVID-19 and people with disabilities in Canada. And what they say, and everyone is saying this as well, if a patient has a diagnosis of COVID-19, then you should be wearing a surgical procedural mask with either goggles or a face shield to cover your eyes. However, if the patient does not have COVID-19, then the Government of Canada is saying you can wear a clear face shield. Now, interestingly, Public Health Ontario has come out with some very good information about face shields as well. And I am going to highlight just here. So for optimal protection, the shield should extend to below the chin and to the ears, and there should be no gap between the forehead and the shield's headpiece. So no part of the face is exposed, and they say that is absolutely essential. With regard to sourcing PPE, the ministry has developed a directory. I went onto it, I was quite impressed with it, and it gives you information as to where you can buy this information. So I'm just going back to the slides. What do we do if we don't have PPE, or you're feeling that you don't have the appropriate PPE? In those situations, if you don't have PPE, you cannot provide in-person healthcare. If you're feeling as though you don't have appropriate PPE, you either don't provide the service, or in both situations, you provide it virtually. Or if you're working in an environment where someone does have the appropriate PPE, maybe think about following a sort of a mediator model. So for example, in a long-term care home, a hospital, an inpatient rehab facility, if you wanted to do a swallowing assessment on someone who does have COVID-19, but you haven't been supplied with the N95 mask, so you're feeling vulnerable, you don't have to go in and do that assessment. You could maybe ask a nurse or someone else to carry out the assessment under your direction. Now, we appreciate it is not going to be the same, but it might be better than not doing the assessment at all. And this is the new normal. So, Samida, we have one more section to do. I have 5 minutes before I hand back to Brian. Is there one other PPE question that I could answer quite briefly?
Sure, yeah, there are a lot of questions that have come through. I just want to reassure everyone that we have received all of the questions. We will be going through them, developing FAQs. So in terms of some of the common themes in this area, there's lots of questions around seeing children and maybe having difficulty with making sure that the child will keep the mask on during the appointment. One of the questions is, if it's very difficult to ensure this with children, that they'll keep the mask on, or to ensure physical distancing, is it okay to not see that particular child immediately?
So I would have that discussion with your employer or with your colleagues. Or you can phone us up and have a discussion with a practice advisor. You can always offer alternative services, maybe virtual care or something like that. But we will definitely put our heads together in practice advice with regard to children, and we will reach out on your behalf to Public Health Ontario to see what their response is. Thank you. So my last section is cleaning and disinfection. What types of cleaning and disinfection should we do? And secondly, what about sound booths and cleaning sound booths? Well, I am going to take that last question first because I am very grateful to Samida Joglekar, our practice advisor for audiology. She has done a lot of search. She consulted with Western University, so thank you. And she consulted with SAC, so thank you as well. And she developed, from a lot of research, the Pandemic Practice Advice number 10 for sound booth cleaning. Now, this went out today and it went out to audiologists. But let us now focus on office and clinic cleaning. So I am now going to go into these two documents. Now, you'll see here we have office and clinic cleaning, and then we have equipment and materials cleaning. I'm just going to highlight some of those areas. Now, what they suggest you do actually with both the office and equipment is that you do somewhat of a scan, a walkthrough, an inventory. So with the office and the clinic, walk through and identify potential high traffic areas, surfaces that could be touched, that are touched frequently, touched by patients, touched by staff. Look at your office furniture, your clinical furniture. How can it best be cleaned? So we have a lot of ideas for you there. Now, I learned a great deal in preparing these, especially the difference between cleaning and disinfection. And we do have information for you on how to disinfect, because they are saying that if a patient touched something after they leave, as soon as possible is the terminology, that you disinfect that particular surface, piece of equipment, material, etc. So here is the information on hospital grade cleaning. Now, in the other document, let me just go back here. and that is the equipment and materials cleaning. There is a section on toys because I know there is a lot of concern there. And what they're suggesting is you're going to have to look at your toys and only have toys that can conceivably be cleaned, and maybe ask parents, again, in your phone consultation before appointments, to maybe bring some toys in that they can then take away with them. So I am just going to go back to our presentation. And I am now going to ask Brian a question. So Brian, during this unprecedented time, who is CASLPO communicating with?
Well, Alex, as I mentioned briefly before, not only do we receive information from these various sources, but we also have discussions with them. So the Ministry of Health has had some 7 virtual meetings with all of the registrars in the province. And we've also had several meetings involving all the registrars through the auspices of the Health Profession Regulators of Ontario, which is the body for all of the 26 colleges in Ontario, including ourselves. We've also had a lot of one-on-one and group sessions with particularly the rehab colleges. So with the physiotherapists, the occupational therapists, massage therapy, dietitians, respiratory therapists. We've had very fulsome conversations with them during the course of this, including at the staff level and at the registrar level. We've also had, of course, communications throughout with other audiology and speech-language pathology regulators across Canada, especially grateful in this regard for the work that provinces like Alberta and British Columbia have done, who opened up or restarted in-person care before Ontario did. Also, the audiology and SLP professional associations across Canada and in Ontario have been of great assistance to us, and it's been terrific to work with their staff at the senior levels and at the other levels as well, including OSLA, Ontario Speech and Language in Ontario, Speech, Language and Audiology Canada at the national level, and the Canadian Academy of Audiology. And as you mentioned earlier, Alex, many of them have put on webinars and other informational sessions, which have been just terrific throughout to also complement what we're doing and what the ministry is doing and other agencies. Okay, I said I would talk a bit about registration renewal, and registration renewal comes up October 1st every year. And I think the question here is that we've received from some of you is whether there will be any consideration for extending the registration period due to the fact that many people in the registration base during this time of pandemic were not practicing or had to reduce their practices or had to take other measures to cope with the pandemic situation. And associated with this is, are you going to give us a break in terms of the annual fees because we are not working or we're experiencing other sorts of hardships? And finally, there's been a group of questions around would the college allow us for this year only to pay in installments? So what I can tell people, Alex, is that the college is actively considering various options in this regard while balancing our public protection mandate and funding our statutory obligations for registration, quality assurance, complaints, and communications, and all the other core services that we have to provide and must continue to provide. So we have to balance that with the concerns, of course, that you are legitimately raising about the fee levels for and the payment of fees this fall. Last week, the Finance Committee of the Council met to begin discussions on this matter. They're having another meeting this afternoon. We will also have some discussions at our council meeting in a couple of weeks. So I can certainly tell you that we will keep you very informed on this. We're looking at what other colleges are doing. We're looking at what other professions are doing, and we will come up with a plan for addressing those questions in a balanced and but sensitive way as well. And we'll be putting this information out well before October 1st.
So Sumida, was there any other questions about registration fees?
No specific questions regarding the registration fees. I continue to get more and more questions about masks, PPE, different measures to take in the office. So we are receiving all of your questions, and we will be going through them, just to let you all know.
Okay. The next area where we've received quite a few questions in the regulatory realm has been in relation to professional liability insurance. And the questions have centered around, should we be increasing or modifying our insurance coverage in case staff or a patient becomes ill despite our best efforts, and they want to take some sort of action based on what they've experienced? And will there be any consideration for new insurance coverage to resume in-person and non-essential services? So first of all, I would say that registrants must continue to comply with the college's bylaw number 6, where you can find all the information on compliance with the current approach to insurance and how registrants must be in compliant with that. Secondly, to answer some of those questions, it is vital that you have discussions with the insurance company that you are contracted with. And finally, it's very important because many of you have had, I know, some difficulty dealing with some of the insurance companies around the provision of telepractice and those services being reimbursed by or covered by the insurance company. For one thing, and we've given this advice many times to several of you over the past weeks, it is vital that you inform your insurance company that CASLPO has had standards regarding telepractice or virtual care since 2004. Virtual care and telepractice is not something new. What is new is that many more people are using it. And that has, of course, concerned the insurance companies, and they have pushed back a bit. But you can certainly tell them that this is a way of providing service that's been there for a long time in our professions and will continue to be more and more something that registrants will be availing themselves of and patients will be availing themselves of.
So Brian, I was wondering if you could go on to work refusal, and then we'll see from Sumida if there are any questions.
Sure, great, Alex. So we've had a cluster of questions that you have sent in around this as well, this topic. So do we have to agree to in-person if a client requests? And some of you have said, well, I have a clinician working for me who may not yet be comfortable going into homes. We've also had a cluster of questions around, I have a family member with an immune deficiency disease. Do I have to see patients in person in these circumstances? So work refusal, of course, is a legal matter, and it is a difficult matter. And so we have the ability to tell you a couple of things about this. One is there are FAQs about redeployment and COVID-19 on our website, and about specifically work refusal, and very important to access that. These kinds of issues must be discussed between employers and employees, and consider alternative modes of healthcare if you're not able to provide the care that you would ideally like to provide. And most importantly, seek legal advice from a lawyer that's versed in labor and employment law. if you want to escalate things to a formal work refusal.
Thank you. So Samida, do we have, I think we've got time maybe just for one question. If there is one question about insurance or fees or work refusal.
There don't seem to be any specific work refusal questions coming through at this time.
Thank you. Thank you. So I think it's important to reiterate what Brian said right at the beginning is, yes, the ministry through Directive 2, the revised one, has said that if you have everything in place, yes, you can go ahead and start services, but it's not requiring you to. It's not saying that you must provide these services. And so if you can provide services in an alternate way, that is what the ministry actually wants. So I am just going to speak to the ongoing registrant support. So we are going to have profession-specific e-forums. And the first one is going to be at the end of June for audiologists. So keep your eyes open for that. And it's audiology patient care in a pandemic. And then in July, we're going to have SLP patient care in a pandemic as well. And we will keep on having these e-forums for as long as you need them. If we have to do it once a month till the end of the year, we are very happy to do so. We will be writing additional pandemic practice advisories if required, and I promise you, we will look at all of the FAQs, all of your questions, and turn them into FAQs from this town hall. Don't forget, you can always contact Samida Joglekar, who is our bilingual audiology practice advisor. You can also contact myself and Sarah Chapman-Jay. We are the SLP English practice advisors, and David Beattie, our SLP practice advisor for French language, and the information is there. Also, I am using this a great deal. It's the Ministry of Health Emergency Operations Center, their healthcare provider hotline. I have found them to be very responsive. I've asked them a number of questions for today and for today's information, and I'm sure I will be phoning them or another of the practice advisors as we put everything together. So Brian, back over to you.
Okay, it only remains for me to say, Alex, a big thank you to all of you for taking the time to be with us today. I want to also take a moment to thank Alex and her team in the practice advisory area of the college for the extraordinary work that they have been doing to respond to your questions and to provide ongoing, relevant, credible, and accurate information. And this is something that they will continue to do over the months ahead. A lot has changed for all of us over the past few months. We have had to adjust to live and work in the new normal. However, what has not changed is your dedication to providing an excellent level of quality healthcare to your patients. What has not changed is your commitment to your professions and your commitment to serving some of the most vulnerable people in society and making their lives better. What has not changed is CASLPO's commitment to do everything we can to support you. We are in this together. We must support each other. We must adapt. We must succeed. We must all strive to stay healthy and stay safe. Let me just draw to your attention, as Alex said, there's many ways to contact us, many ways to access information, including Facebook, including our publications, including the dedicated COVID-19 page. So please keep in touch. This is not a one-off. We know you will do that. You've been fantastic in terms of all of the questions you've been asking us and all the interaction we've had with you. So thank you again, and I think we can wrap it up and say goodbye, and we look forward to further interactions over the next while. Thank you all very much. Stay healthy and stay safe.
Thank you.